So we're going to review the Obecabtagene autoleucel for relapsed refractory B-cell ALL, obviously the FELIX study. So these are the approved CD19 directed CAR T-cell therapies for relapsed refractory B-cell ALL. You can see the first approval in 2017. So the circles represent the FDA approval, the triangles, the European approval, and there's some slight differences that we've highlighted in the box. Tisanciclusel or Tisa-cel, the first approval in pediatrics and young adult patients up to age 25. Brexacel, adult patients with relapsed refractory B-cell, slightly different age in the European venue, and same thing with obecabtagene or obe-cel, recently approved in 2024 in the US and 2025 in Europe. So these are the differences between the three CD19 directed CAR T cell therapies. Tisa-cel and Brexacel use the same high affinity SCFV fragment to recognize CD19. Obe-cel is a different construct with intermediate affinity, this so-called fast binding or off rate, which may impact toxicity and CAR T cell persistence. It's also important to note that Tisa-cel and obe-cel are 4-1BB constructs, and Brexacel is CD28. The other interesting difference between the agents is Tisa-cel and Brexacel are administered as a single one-time infusion, whereas obe-cel has a split dose, which is based on a bone marrow prior to the start of lymphodepletion. And here's the diagram, the ORT diagram for the phase 1/2 multicenter study. 150 patients or so, 153 to be specific, were enrolled in the phase 1/2 study. 127 received infusion. There were 16 patients enrolled on the phase 1B and 111 on the phase 2 portion, which consisted of three different cohorts. The primary endpoint, which was cohort 2A, which consisted of 94 patients with morphologic disease defined as greater than or equal to 5% blasts within the bone marrow. Cohort 2B was an exploratory MRD, and cohort 2C had isolated extramedullary. And you can see that these consisted of very small subgroups. It was the 94 patients that consisted the primary efficacy endpoint, and the safety consisted of all patients. And this is the diagram that I'm sure everybody's seen before for the study design. There was a bone marrow at lymphodepletion before lymphodepletion that assessed the disease status and the split dosing strategy. So just to get through this, there was a screening bone marrow done prior to enrollment. Patients who were eligible had a leukapheresis, and then they may or may not have received bridging therapy based on the investigator's decision. And then a second bone marrow was done within 6 days of the start of lymphodepletion, which consisted of 4 days of fludarabine and 2 days of cyclophosphamide. And you can see based on the burden, there was an adjustment of the split dose. So if the bone marrow blasts were less than 20%, 100 million CAR T cells were administered and in the initial dose, and as long as there was no CRS greater than 2 and no ICANS, a second dose around day 10 of 310 million cells was administered. The total was 410. If the bone marrow blasts were greater than 20%, the dosing was slightly altered, a lower dose initially at 10 million. And then again, if there was no CRS greater than 2 and no ICANS present around day 10, the remaining 400 million cells were then administered. And here's the key efficacy endpoint. Again, this is cohort 2A, consistent of patients with morphologic disease. Median follow-up about 20 months. The overall remission rate was about 77%. And you can see here how that is split. 55% of patients were in complete remission, and another 21 complete remission with incomplete count recovery. Patients who had received at least one obe-cel infusion, again, it's defined as 2 total. So you either got one or two. And so patients were evaluable if they got at least one. And you can see here the median overall survival was 15 and a half months, and the median event-free survival was approximately 12 months. I think importantly, looking at the safety, and this included all 127 patients who received obe-cel, so not just cohort 2A, the CRS and the ICANS rate were extraordinarily low as compared to other agents, and we'll have a comparative slide later. Grade 3 or greater CRS occurred in 3 patients or 2%, and ICANS grade 3 was in 9 patients or 7%. And you can see the rates of febrile neutropenia and infections listed there. So again, tumor burden guided dosing really assessed and mitigated some safety concerns. You can see here, based on the low tumor burden versus high tumor burden, there was slightly improved CRS and ICANS, although the rates for both groups was extraordinarily low. In terms of the efficacy, the patients with low tumor burdens, as we've seen with other agents, really does correspond to a improved efficacy with an overall remission rate of 85% in those patients with 20% or less blasts versus 73% for patients with 20% or more blasts. As you recall, the overall remission rate was 77%. Here, T cell persistence does predict clinical outcome with obe-cel. Different ways of looking at it. The study actually looked at PCR methods. Those are proprietary. Most of us in the clinic, outside of clinical trials, have been using B-cell aplasia. But just to walk through this slide, median follow-up of almost 33 months. Again, PCR was used to assess CAR transgene levels in the peripheral blood, and 79% of patients who achieved a CR or CRI had ongoing remission beyond month 3, and ongoing persistence was seen in about 76% of patients. And you can see here the median event-free survival, 24-month event-free survival, and 24-month overall survival was improved in those patients who showed persistence of the CAR T cell in month 3. Next. This was data that was presented by Dr. Jabbour from ASCO in 2024, showing the effect of CAR T cell persistence at 6 months. The last slide was 3 months. And again, to recapitulate the same observation, that persistence of obe-cel at 6 months led to improved event-free survival. And again, ongoing B-cell aplasia also correlated and predicted event-free survival. Next. So here are long-term findings of obe-cel in this relapsed refractory population, looking at 3-year duration of remission, event-free survival, overall survival, with a median follow-up of about 33 months. And in the two groups are censoring for consolidative transplant versus those without censoring. And you can see really impressive duration of remission, probability at 12 months of almost 62%, and in event-free survival at 12 months of about 50%. If you censor for transplant, you get, again, very similar results, probability of event-free survival of 61%. So findings indicate patients may not require additional therapy post obe-cel. However, longer follow-up and further analysis is warranted. There were differences between the patients who did get subsequent transplant versus those who did not. So I think that is something that we should discuss later. Most of the patients who did not get a subsequent transplant were patients who were relapsed post-transplant versus those who were transplant naive, had a higher proportion of getting a subsequent transplant. So here are the outcomes stratified by age, which I think is an important consideration for obe-cel. There were some older patients, including patients as old as 80, included in the trial. So this was stratified by patients less than 55 or greater than or equal to 55. And there seemed to be no significant outcome in terms of event-free survival and overall survival between the two groups. If you look at patients greater than 26 years or patients even greater than 65 years as exploratory cohorts in columns number 3 and 4, you can see the values there. So age really didn't seem to be a significant factor in terms of event-free and overall survival. The other important, which is not included in the slide, but included at the conclusion at the bottom, is that the incidence of grade 3 or greater CRS or ICANS was low in all groups. So factors predicting clinical outcomes, in multivariate analysis, independent factors were associated with improved outcomes, including obe-cel persistence. I showed you that data at month 3 as well as month 6. Low disease burden still is an important factor in terms of predicting outcome. And this is, again, the disease burden prior to lymphodepletion. Because some patients had bridging therapy, some patients didn't. Other factors that were correlated with higher remission rates, interesting, the Philadelphia positive disease, probably because these are patients treated with less chemotherapy, would be my opinion. Most of us are using TKI-based approaches and less chemo for our Philadelphia positive, and they have correlated with higher remission rates. Earlier obe-cel use, that is, earlier lines of therapy, less refractory disease, is another way of saying the same thing. Patients who achieve MRD negative remission, responders always do better than non-responders, of course, and those patients who achieve a MRD negative remission do markedly improved. If you look at the table at the bottom right, you can see the tumor burden less than 5%, 5 to 75%, greater than 75%, and the effect on event-free and overall survival. Again, just stating that disease burden at the time of lymphodepletion is important. And here we can see the real-world evidence. Sometimes this is useful. Patients, as we all know, participating in clinical trials, it does represent a subset. And so this was an ability based on the ROCA analysis, which I think has become a very powerful analysis looking at real-world data for CAR T-cell. 40 North American institutions have participated in this data set, including patients with relapsed refractory ALL. In this particular subset analysis, there were 53 patients treated with Bruxa-cel and another 36 patients treated with obe-cel. And here, really just looking at safety, is the safety that was reported in the FELIX trial, what folks are seeing in the real world. And here, although you don't like to make comparisons, this is why between trials, this is why this real world analysis may be somewhat helpful. And here you can see the incidence of CRS between Bruxa-cel and obe-cel, with obe-cel seeing a statistically significant reduction in CRS as well as ICANS. And in the bullet point, the grade 3 or greater CRS was 6% in Bruxa-cel, which is lower than what was reported in the Zuma trial, and 0% in obe-cel, again lower than reported in the FELIX. And you can see the ICANS, the 32%, which is almost identical to what was reported in the Zuma 3, and 6% ICANS, which is about the same that was reported in the FELIX. This is overall safety, just looking at the conclusion. I mean, in the FELIX trial, when we subset analyzed based on disease burden, there were subtle differences that I showed earlier in the CRS and the ICANS, but they were very subtle differences. They were more dramatic in the Zuma trial with Bruxa-cel, but this is looking at all comers, which is how the manuscript was initially presented. So your point is valid that it may be better to break it down, but this is how it was reported in the paper. So some future directions. These are some ongoing clinical trials split between adults and pediatrics, moving down the adult arm. Earlier administration of CAR T-cell. I mean, this is what we've all, fantasized about. There's some ongoing clinical trials, phase 2 trial of obe-cel as consolidative therapy for adults. There was some hint of some early data at ASH 2025. There's also obe-cel being used as consolidation therapy in adults in first complete remission without MRD. So this idea of earlier intervention with CAR T-cell therapy, maybe a standalone without transplant even. And the pediatric arm, because obe-cel is approved in adults, different ages depending on the FDA and European approval. And so there's an ongoing phase 1b/2 trial of obe-cel for pediatric patients under age 18, with initial findings shown in the box with a high overall response rate and over 90% of responders having ongoing remission. But again, early data for the pediatrics. So in conclusion, keeping within the time, currently there are 3 FDA and European approved CD19 targeted CAR T cells, depending on the age. For pediatrics, it's Tisacel. For adults, depending on the age again, you have Tisacel, Bruxacel, and obe-cel. Obe-cel is an autologous fast off rate 4-1BB CD19 directed CAR. Clinical efficacy in adults demonstrates in the phase 1b/2 FELIX trial that we reviewed. Analysis of the FELIX trial highlighted several factors that can predict outcomes, including MRD status, post-CAR, low disease burden at the time of lymphodepletion, the administration of obe-cel in earlier lines of therapy, and the importance of CAR T-cell persistence at 3 months, possibly even 6 months. Real-world evidence based on the ROCA data that we reviewed suggests that the rates of CRS and ICANS in patients with relapsed refractory ALL treated with obe-cel are similar to those reported in the FELIX trial, and ongoing trials assessing earlier lines of use of obe-cel for treatment of adults, as well as evaluating its efficacy and safety in pediatric patients are ongoing. Is discussion points. And we can break and go through this. I think the biggest question is, where do CAR T-cell fit in the, becoming definitive therapy, i.e., how are we using it in each of our own clinical practices in regards to stem cell transplantation? And how does CAR T-cell therapy impact the treatment paradigm moving forwards in terms of replacement of transplant or even consolidated therapy? We saw some early small studies presented at ASH, and I know, speaking for myself, they seemed very provocative. Several factors associated with clinical outcomes were highlighted in the FELIX trial, including MRD, tumor burden, and CAR T-cell persistence. Be nice to discuss that as well. And how can we further improve outcomes with CAR T-cell therapy? So why don't we try and go through, and I know that we discussed some of these along the way, but maybe we can open it up for some comments.
Dan, I can start. I mean, we all want to actually use CAR T-cell therapy as a definitive therapy in relapse refractory setting. But the reality, I mean, relapse after CAR T-cell therapy has really extremely poor outcomes and limited therapeutic options, especially if they are CD19 negative disease. So most of us, if the patient is transplant naive and fit and they have a donor, we still transplant these patients. There are all these factors, persistent clonoSEQ negativity after, can help us in kind of predicting which patient have more durable remission. But typically this decision about transplant versus not transplant is done before the CAR T-cell therapy. Now, for all of us, I mean, if we have a patient where we don't think transplant is an option, I think this is the treatment that we hope that it will give the patient durable remission and possibly cure. But as you mentioned, I think the goal will be to move the CAR T-cell therapy early in the treatment paradigm of ALL. And we think this is where it can be more curative treatment, definitive treatment, rather as part of kind of other consolidation, including the transplant. That's my only view. I mean, it's relapsing with CD19 negative seems to be a problem after obe-cel. It seems like for any 4-1BB co-stimulatory CAR, they're more likely to relapse CD19 negative compared to something like Tecartus, where you see more CD19 positive relapse.
Yeah, I think that's because of the persistence issue, right? The
Exactly.
4-1BBs have a more durable persistence. The CD20, we didn't see the effect of persistence in the obe-cel past 6 months. It really wasn't associated with, a bit with the Brexucel wasn't associated with a improved remission duration. But I do differ a little bit in terms of some questions. Is those patients who have relapsed refractory ALL who are transplant naive versus those who are post transplant. I think there's a difference in terms of how I approach them. Whether or not am I going to use a second transplant after CAR T cell or not, and I'm not sure that the data supports that. I do agree with you, though, Ibrahim, in a patient who's transplant naive, that it's hard to not want a transplant. I know that's a double negative, may not be perfect grammar, but we will still at least err on the error of transferring. And I know Aaron Logan had some interesting data looking at, transplant at some point was associated with a better outcome. It wasn't really clear that two transplants were better than that. I don't know if others have thoughts.
Maybe to be provocative, I do think that such a sophisticated and expensive therapy should be seen as a replacement of transplant because it's the target to take off all we think about sequelae of transplant. And we have now in pediatrics many, many long-term patients surviving without having any transplant after Tisagen leucocell. I do agree that it is not the same product that Brexucell, which is a short-lived product. For obe-cel, really the hope is the persistence because of the so-called fast on, fast off. If true, then it could be a replacement therapy. And that's why we need studies and prospective ones, which is obviously the difficult part of the question.
Yeah, I agree. I think that's a good point. The one thing that I always comment on is that, as I alluded to, which I really didn't have time to dive down, is if you look at the group of patients treated in the with obe-cel who did not get a post CAR T cell transplant, the vast majority, 2/3 of them, had already had a transplant. Versus the group of patients who were transplanted post CAR T cell is a little bit different demographics, but I completely agree. These are expensive things. But then Ibrahim's, valid is, you don't want to, if a patient has a CD19 relapse, you're really kind of limiting what you can do after that. Anybody else have any other thoughts? How do you practice in your own institution with respect to the approach of transplant post CAR T cell?
Oh, if I may comment, I agree that persistence is, I think, a center issue questions for treating this patient. So to replace allogeneic stem cell transplant frontline or in relapse, I think we would be happier with long-lasting CAR T, even if we don't know, and probably there is an heterogeneity of need to persist for CAR T according maybe to different disease characteristics or biology, and there is little data so far to understand why. In the context of short persistence, some patient will have a long-term survival without relapse and without any other intervention, including allogeneic stem cell transplant. So understanding in which condition CAR T cell persist or not would be very helpful to guide the decision, and it's what we try to do with Tisagen on a daily practice. As it was mentioned with Brexucel, we know that the short persistence is associated with a higher risk of CD19 positive relapse, so that we try to bridge this older patient to transplant when it's possible. And then in Europe, as you know, we have so far little experience, well, not to say no experience with obe-cel, unfortunately. So, but it seems to be probably better in terms of persistence than the other CAR T that we have for older patients.
Can we discuss the latter two points? I'm curious to see what others do. Uh, there is a, we see that we saw this with blinatumomab as well in the Tower study. We didn't see it in the Innovate study with inotuzumab, but the idea of these biologic agents really having the disease burden at the time having an impact on outcome, and I think the FELIX study, because of this requirement for a lymphodepleting a bone marrow prior for lymphodepleting chemo, and then the split dosing difference. But no matter how you look at it, whether you're looking at persistence or outcome, MRD, there's always in a multivariate analysis an impact of disease burden in terms of outcome. And so, how are folks bridging patients prior to CAR T cell? In the FELIX study, it was an option, and sometimes we did a less is best, try to just tweak the patient on. But then you have the data that I showed where it really impacted outcomes. So what are folks doing in the real world in terms of you see a patient with 80% blast? Are you making every effort to get that patient into a lower disease burden? And how are you doing that? Chemo, inotuzumab, which is what we've done. But then if you're going to do a transplant, so what are others doing?
Yeah, then for us, I mean, we always try to bridge. I mean, even if kind of low level of disease, we try at least maybe low dose chemotherapy or steroid. For the chemo refractory, I think this is the challenge. Some of those relapse refractory PH-like, they're very chemo refractory. Doing intensive chemotherapy unlikely will induce enough cytoreduction, but it can be toxic. We tend to do more like mini CVD, venetoclax. We find out it is really very effective and low toxicity regimen. I try to avoid intuzumab because we still transplant many of these patients after transplant, but some of the cases, I mean, they're very chemorefractory or they had prior venetoclax. We end up giving them intuzumab, either alone or part of low-dose chemotherapy. If there is extramedullary disease, sometimes we give kind of medium kind of intensity chemotherapy to try to cytoreduce these patients.
But you try to cytoreduce to what point? I mean, are you really pushing it down to 20%, 5%? What are you trying to do, Ibrahim?
I mean, the goal remission, to be honest. I mean, seems best outcomes if you have low disease burden defined as less than 5% plus in the bone marrow. But, you try, not necessarily will be able to achieve, but I won't delay CAR, infusion, LD, and CAR, unless there is really like a circulating plus. In these cases, I have delayed CAR until I clear the circulating plus. But again, sometimes, unfortunately, cannot be successful, and the definitive treatment is CAR. You understand you anticipate there will be more toxicity, less efficacy, but I mean, the CR rate is still high in these patients.
Yeah. Others?
I would say that similar to what you've both said. I don't actually have that much experience using the CAR as probably for sure as many of you, but we always do try to cytoreduce as well, and we have used inotuzumab and have gone on to transplant after without in the limited number of cases without additional worries, without additional toxicities.
And your goal of cytoreduction is to get patients into remission, or
Yeah, but I was interested to hear what Ibrahim just said. I mean, I also think the goal is to get them in a controlled state and a cytoreduced state. So I would say, yeah, the hope would be maybe if they're in a remission, but we would not delay. We do not delay the CAR to keep pushing to get to a remission state. So I think one try, and if there's good cytoreduction, go ahead, and if there's not, probably still go ahead, I would say.
Yeah, my approach has changed. When we were enrolling on Zuma 3, we were trying not to harm, do no harm and get the patient to CAR. And now with the data from the FELIX, we're a little bit more aggressive, like Ibrahim, and trying to get the patient into a remission if we can. again, and as you said very elegantly, Ibrahim, there are patients who have refractory disease, so we don't want to delay the CAR. But we were a little bit more aggressive. And we also use a lot of inotuzumab, like Wendy, maybe more than you do, Ibrahim. But the mini hyper CVD is a nice approach that we've taken. But sometimes you need to use high dose chemo, especially in the extramedullary disease. But we're a lot more aggressive now. At least I'm more aggressive.
But
Because
Dan, do you give more than, I mean, do you actually give more than one cycle? Just you keep
sometimes I have to in order to get disease control, because I mean that's, yeah. But I don't want to, I don't want to delay too much, because then then we come to the last bullet is, mitigation of infection and things like that. Because, the more is not always more. So I don't want to delay too much.
Yeah.
And so how are people approaching infection management in patients with CAR T cell? We have 5 minutes left. So why don't we finish with this topic and then we can close on. Are everybody prophylaxing? What are people doing? I mean, at our center, we've been given, obviously we use, PJP prophylaxis with HSV, VZV, and then we'll do monthly IVIG infusions. I think that's what most of us are doing, and monitor appropriately. But, you have patients that come in sick, and the more chemo you give up front, the more they are. Anybody taking a different approach? Has this been an ongoing issue?
I think it's one of the leading problems with this refractory patient is infection, fungal infection, bacterial infection. So yeah, we do the same. I mean, prophylaxis, including azoles like Posa or voriconazole. The IVIG will try to give it, but we have some randomized study where they actually compare IVIG versus not IVIG in these patients. So some of the patients, they go on these studies since the data is not very clear. Then the question, would you vaccinate after CAR? I'm not sure what you guys do it done. Do you vaccinate?
So we follow the transplant guidelines, and it depends on if they're going to get to transplant. So we do continue the vaccination approaches like our transplant colleagues.
Yeah, we haven't been vaccinating actually after CAR. But again, many of our ALL patients end up going to transplant, then they receive the vaccines after transplant.
Anybody else? Any other?
I must say, Dan, that the main concern of infection is more in the bridge period than in the post-CAR immediate period, in fact. And in the post-CAR immediate period, we do not have so many infections, by the way, because the flu-cy regimen with 420 flu and 1 gram cyclo is not so intensive. So we prophylaxis like you do, and we do not have many infections. The more severe we had was many years ago in a heavily transplanted patient prior to CAR. We have who have an HHV6 plus toxoplasmosis infection, but in most of the cases, the infectious problem we had were prior to CAR than after CAR.
And are you repleting your IgG in patients with B-cell aplasia?
No, we begin the immunoglobulin generally after months 1 year.
Yeah.
And we maybe one thing you do not have quote is the use of GCSF, because what we see is generally the increase of polynuclear and then they fall down. And so between day 14 and day 30, sometimes they receive some GCSF until they recover from neutropenia.
Are other people using myeloid growth factors?
I've been using it frequently as well as Eltrombag. I mean, I think with obe-cel, Dan, I'm sure you're seeing the same. It's prolonged cytopenia in some patients.
Yeah.
Yes.
Yeah. But I don't know Promacta will help or not. I've been giving it to my patient. Eventually they recover. I don't think it is the Promacta help usually. But the GCSF were very aggressive with it too.
Us too.
Starting when?
Very early. I mean, typically we start like maybe day 3. If there is no active CRS, we tend to give it early.
Yeah, we tend to wait just a little bit longer because of the concern of exacerbating CRS,
Yeah,
but
same here.
we also start it fairly early because we have seen very prolonged cytopenias. That's been one of the most vexing problems actually for some of our patients post obe-cel.
On the other hand, do you use TPO agonist in case of delayed thrombocytopenia?
We've tried. It hasn't always been very effective, I have to say.
I
And
agree with you.
as I said, I don't have the world's largest experience, but we have used it, and we've even had to in patients. Of course, I'm just thinking of the most recent patient who was post allo, and we had to actually infuse stem cells um, from the donor because this was a donor CAR,
Oh, interesting.
and
Yeah, we have
that's
not been
months
using
later.
we haven't been using TPO-mimetic agents very often. I've only used them a couple times. I don't know if it's worked or just the time that affects, but I do agree with GCSF. You just have to be mitigate the CRS issue.